Good afternoon, everyone, and thank you for joining us today for our Mott chat. Today's web chat topic is springtime asthma triggers and other asthma FAQs. We would like to thank you all for joining us. We have a great topic today, but we'll go ahead and start with a few housekeeping items. We'll start today's program with a brief presentation from our panelists, and then we'll open up the floor to Q&A. But you can start submitting your questions anytime. You can email us your questions to mottchildren@umich.edu. That's mottchildren@umich.edu. Or you can tweet us. Just use the hashtag MottChat, which you can see up in the right-hand corner of your screen. We will take questions all the way up until 1 o'clock, but please feel free to start sending them so we've got a nice queue together for our panelists. After today's web chat, we'll be archiving the entire presentation, so if you have to leave early or if you just enjoyed it so much you want to watch again, you're welcome to come to our website, www.mottchildren.org/webchats, and the entire broadcast will be archived there for you to view afterwards. We also have archives of past web chats if you want to check out what other topics we have there. Also, after today's chat, we'll be sending out a brief email survey that we'd like to ask you to take a moment to complete. This is just an opportunity for us to find out what we can do to improve future web chats, and we would love to hear other topics that you'd enjoy hearing specialists from Mott talk about. With that, I'll go ahead and introduce our panel. Today we have Dr. Ixsy Ramirez, a pediatric pulmonologist with CS Mott Children's Hospital, and Karla Stoermer Grossman, a nurse and patient educator with the Comprehensive Asthma Wellness Program here at Mott Children's Hospital. Thank you both very much for joining us. We'll go ahead and start with Dr. Ramirez. Can you give us a brief overview of pediatric asthma?
Sure. So I'd like to say thank you for having us today. We're very happy to be able to do this web chat with everyone out there who's watching right now. So what is asthma? Asthma is a chronic airway disorder with reversible airways obstruction. And it has three components to it. There's airway spasm, which is evidenced in the asthma attacks that may occur when a patient is having a hard time breathing. And so the airways are tightening during these times. There's the underlying problem of asthma where there's a chronic airway inflammation. And again, the airways are narrowed, but this time they're being narrowed because of the airway inflammation itself. And finally, there's mucus production that occurs after there's a significant amount of airway inflammation and recurrent spasm attacks. Asthma is the most chronic illness of childhood, and it's the #1 chronic illness leading to school absences. So in the United States, about 7 million children are affected by asthma between the ages of 0 and 17 years of age. About 80% of these children have had an onset of asthma by 5 years of age. And it's the underlying airway inflammation that we are working to manage when it comes to asthma. It's this airway inflammation that leads to the common symptoms of cough and wheezing. This can sometimes be associated with shortness of breath or chest pain as well. By far, the most common symptom can be a cough. And there may be some children who may never wheeze. So just because a child does not wheeze does not mean that they don't have asthma per se. They may only have a symptom of coughing. So asthma can be triggered by a variety of different stimuli. And the most common stimuli by far are viral illnesses. And this is then followed by allergens, as we may talk about today. And then asthma can also be triggered by increased physical activity, as well as irritants, which we don't want to forget about. These are very important, and strong emotions as well. Now, when it comes to viral illnesses, the most common viral illness causing asthma exacerbations is rhinovirus. And rhinovirus is our most common virus out there. It's the virus of the common cold. And when it comes to allergens, common allergens can be animal dander, such as cat and dog. They can be pollen, trees, dust mite, and even cockroaches. So we do want to try to address all of these potential stimuli at any point in time to have good control of asthma. Now, we are at an interesting time of the year right now because this April to May season, we are actually at a crossroads where winter season is thawing out and spring is emerging. And so we are actually being exposed as you cough, Karla,
Yes,
right?
yeah.
Because we are being exposed to both viruses, with rhinovirus being that common virus once again, and the early allergens of spring. And so this includes our trees and includes our pollen. So this can be a very difficult time for children or anybody who has asthma. But by far, fall and winter season can really be the more common time of the year when children with asthma are having issues because, again, viral illnesses are still going to be your main trigger. When it comes to irritants, we can't stress enough the importance of avoidance of different types of smoke. And most importantly, we want all children who have asthma, and anyone really, to avoid tobacco smoke and being exposed to tobacco smoke at any point in time. But other types of smoke that we would want families to avoid as well would include wood smoke. So this includes, especially here in Michigan, heading up north during spring and summer season, or having bonfires in our backyards, or heading up north and having bonfires. We try to avoid that smoke at those times as well. And then other irritants can actually include perfumes, household cleaners, or the use of candles in the home. So these are all things to keep a lookout for. When it comes to the diagnosis of asthma, we take a variety of factors into play. We definitely take into consideration the patient's history when it comes to their symptoms. And what are we looking for? We're looking for children who have had a cold that has lasted a lot longer than expected. We usually expect a cold to last about a week or so. So any cold that lasts longer than that time frame, that should be a red flag for a family or a primary physician. Any cold that a family may describe as going to the chest, or a child that has a cold that always goes to the chest, is another reason to consider an evaluation for asthma. When it comes to family history, we do want to look at the first-degree relative and whether or not a first-degree relative has asthma. Mm-hmm. The most important relative that we care about is actually mother. Because with a mother who has asthma, now there is a 60% chance that their child will also develop asthma. And then when it comes to the child's medical history, we look to see if that child has a history of eczema, because the connection or the association of eczema, seasonal allergies, or any other type of allergies really, and asthma all go hand in hand. And this is known as the atopic triad. So treatment options are twofold. We want to be able to treat asthma exacerbations, or these acute attacks of asthma, and we try to relieve the airway spasm that I mentioned earlier. And this is the narrowing of the airways that occurs during a asthma attack. And so we do use bronchodilators, otherwise known as short-acting beta agonists, and a common household name is albuterol. And so this medication works to serve in the acute setting to help relieve the airway spasm. On the other hand, we try to address the other components of asthma, which is the underlying airway inflammation and that mucus production. With the underlying airway inflammation, we try to achieve good control by using controller medications. And I want to point out here that the gold standard of treating the underlying airway inflammation is with the use of an inhaled corticosteroid. And we'll go into that a little bit later. So generally speaking, we have different forms of medications that we use. We have relievers and controllers that I just mentioned, and so they come in various forms. So I'll have Karla here go over some of those types of medications that we have available.
Wanted to show a picture or quickly of what we're dealing with inside the lungs. So here you can see the swelling in the airway. That hole in the middle should be much bigger. So you're going to get that air in and out, and then there's swelling, and there's mucus production. So what we're going to try to deal with is take that medication and have that, treat that and get that opening bigger. What you want it to look like is something like this, where there's no swelling, there's no mucus production, and the airway is much more open. And to do that, we take different medications in different ways. We have things called meter dose inhalers, which is just a canister with a boot here that we can press this and the medication comes out. And then we want to make sure that that's always used with children. We always want to use a chamber with that so that medication is captured and put into the lungs more easily. We also have things called like the discus. This is a specific type. It's called Advair, but it's a dry powdered inhaler. These dry powdered inhalers also come in different formats here. I'm sorry, I'm having problems with the mirroring here. Have different forms, but different ways of taking those. And each of these devices have different ways of taking the medication, very specific. So it's really important that your primary care provider, your specialist, talks to you about how to take that medication so you get the best results with that. There's also the nebulizer, which I think a lot of people are very comfortable with, which is a box with a machine that you attach tubing to, and it has a little cup on the end. You put the medication in, and then that medication comes out as a mist, and you need to breathe that in. So there's a lot of different ways to get medication in, including pills and liquids. But again, how you use this medication is really crucial. So understanding exactly how to do that is really, really important.
All right, thanks. So the decision to go ahead and choose any one of these types of inhalers or devices that Karla has just reviewed really takes a lot of different factors into consideration. We definitely take input from parents, take input from the child if they're old enough to be able to let us know what they are interested in using, what they're willing to use, and then of course medical staff. And so it's really a team effort in being able to come up with a good regimen that balances control of asthma symptoms while allowing the patient to adhere to the medication that we are setting forth for them. Really, I just want to point out here that also it's important to have an open and honest discussion, about adherence to medications, whether that be with your primary physician or with one of the doctors in our pulmonology clinic. We try to do our best to provide a good regimen that is convenient for families, but there are instances where asthma may be a little bit more difficult to control, and so we may not be able to only control symptoms with one medication alone. But by having that open and honest discussion about whether or not someone's going to be willing to adhere to a certain plan really helps us out to come up with a plan that everyone is willing to buy in.
Yeah, the major point is that most of these medications need to be taken every single day and sometimes twice a day. And if you don't take those medications twice a day, then the asthma won't be well controlled. And if we don't know that, if you're not feeling comfortable telling your provider that you're having difficulties like taking your medicine in the evening because everything's so busy, that we might actually end up increasing your medication without really knowing that. And we don't want to do that because we want to have the least amount of medication for the best control. So being really honest with your provider about whether you can take that schedule every day. If it's really difficult to do, there's different things we can do to get that schedule to be easier, hopefully, and then we'll have better, you're taking that medicine every single day, you'll have better control and less symptoms.
Essentially, the goals of treatment are to address the underlying airway inflammation that takes place in the airways of
swelling again
of the bronchi themselves. And by doing so, and by minimizing the airway inflammation, we're then able to minimize or resolve the symptoms that are associated with asthma, that cough, wheeze, shortness of breath. And if there has been any sort of previous physical activity limitation, we want to be able to improve upon that and allow children to be able to get involved in any kind of sports they want to do or physical activity, and we want them to be able to keep up with their peers. Additionally, we want to, by addressing that airway inflammation, we want to be able to minimize the hyper-responsiveness of the airways. We don't want these airways to be twitchy to any stimuli that are coming its way. And so that may include those viruses that I mentioned earlier, or the various allergens and irritants that the airways can be exposed to. And overall, like I stated, we just really want children to be able to lead an unrestricted life without having any type of asthma symptoms. We want to be able to allow them to feel as though they are just as, able as their peers to be able to do physical activity, go to wherever they want to go, and not feel that they can't breathe or are having too many symptoms that they need to stay at home and can't do that.
The object really is to sleep through the night, play through the day, and be close to normal as possible with taking that daily medication every day.
Yeah, and so with taking that daily medication on a regular basis, once good control of asthma is achieved with the use of the controllers, the relievers really don't need to be used on a regular basis. They should only be used on an occasional basis. But at any point in time, the airways are always at risk of being inflamed, and so that's why we stress the importance of using the daily inhaled steroids, because we don't want these airways to continue to be hyper responsive to every little stimuli that comes its way, and thereby leading to airway exacerbations.
Right. Emergency room visits and hospitalizations should not be occurring, or should be happening very, very rarely, depending on the severity of your disease. So if you have a kid that's been in the hospital multiple times, or been in the emergency room multiple times for asthma, that's really a clear indicator that that asthma is poorly controlled, and you really do need to talk to your provider, maybe being seen by a specialist, and getting that better control.
So at the University of Michigan Pediatric Pulmonology Clinic, we take the time to evaluate a patient's history, be able to diagnose their asthma, and provide asthma education and any information that we can help families to try to help manage asthma. So I'm going to have Karla actually go through what it's like to come into clinic to see us.
Well, our clinic is kind of interesting because we work in a multidisciplinary team. So we have the pediatric pulmonologist, and we have myself as the certified asthma educator, and then we also work with a social worker that can help with the issues of maybe not being able to purchase your medications, or there's problems with insurance or transportation or housing or other things. So it's nice that we have this team that's always there for you. We initially every patient, if they're older than probably about 6 years of age, gets spirometry, which is the breathing test. We can actually look how the lungs are working. And then the doctor will review that, and our asthma control test. We look at those numbers, and we look at the asthma control test, and we talk to the patients every time about, have they had daytime symptoms? Have they had nighttime symptoms? Have they had symptoms with exercise? We put that all together, along with the history of what's been going on since the last time we saw you, or since you before you've seen us. And then we kind of put together a plan. We look at that and say, okay, is there any issues of things that we can fix really easily by either looking at your technique, because again, using these inhalers can be a little challenging. And so we look at your technique and make sure that that is being done correctly. And if we can make any corrections, help you with that. And then we see if there's if we need to make any kind of changes to the medication regimen. And we can make that. And then we should always come out with an asthma action plan that tells you step by step what to do. And it tells you when to call the doctor and how to call the doctor, so you feel very comfortable of what to do during an asthma exacerbation. The neat thing about our clinic is that you always have a doctor on call. So even in the middle of the night, if you're having problems with your child's breathing, you can call one of us and have the doctor on call talk to you through about what's going on. We also do a lot of education about what asthma is, how to handle it, how to use your devices appropriately, how to handle asthma in the school. We can help you with school. Sometimes kids need special plans with school and taking those medications, or having sometimes activity and other things, so we can work with the school with that. And I think the comprehensiveness of the program is really an asset for most parents. We can help out with a lot of things that sometimes parents really feel like they're alone in. We always ask you what questions, and you should come with questions to any of your providers. Always make sure you write those questions down, so you make sure you feel like you get those questions answered before you leave the office. And then we see our patients pretty frequently. We see them every 3 months because we want to see how your asthma responds over the whole season. Because some people are worse during the winter, some people are worse during the summer. I can tell you right now, I have a cold and an allergy symptom. So this is spring, and as Dr. Ramirez was talking about earlier, this is really that convergence of those two problems. So I have started my albuterol, like I should, by my asthma action plan, and I'm watching it closely. So I know if I take too many doses of albuterol, I should be, or this number, specific number of doses of albuterol, I should be talking to my primary care or my specialist. So we send you out with a plan, and so you know what to do and how to do it and when to do it.
And aside from our asthma wellness clinic, of course, we see children with asthma children with asthma are seen by any one of our physicians in our group. So it's not just necessarily our asthma wellness clinic. So, in our office, we are able to treat a wide variety of severity when it comes to asthma, complex asthma when it comes to other factors that are coming into play, sometimes muddying the diagnosis a little bit too, so we can work through that. So when is a good time to be referred to an asthma specialist or pediatric pulmonologist, a lung specialist? Good times would be if your child has ever had a life-threatening exacerbation of their asthma. And what does that mean exactly? That means having been admitted to the pediatric ICU, whether or not they've been intubated or needed a breathing tube with a ventilator, a breathing machine for them. This is a sign that their asthma is very severe and that they are at high risk for mortality. Other times is just if a child has not been admitted to the pediatric ICU, but just generally speaking has severe asthma with frequent symptoms. That's another time to be referred.
Or multiple ED visits,
yes.
Emergency room visits, yeah.
Yeah, these are all signs that asthma is that their asthma is at high risk and that their asthma is not well controlled. Sometimes a pediatrician or primary physician just needs a little bit of assistance when it comes to the actual diagnosis of asthma. Again, like I just briefly mentioned, just sometimes asthma can be very complex and there are other factors that come into play, so the diagnosis may not always be straightforward.
Totally clear, right.
And finally, once a child is diagnosed with asthma, let's say by their primary physician, and they have been started on an inhaled steroid or have been using a short-acting beta agonist, that reliever medication known as albuterol, and perhaps they're not getting good control with their symptoms after about 3 to 6 months, that's probably another good time to be referred to us. And so with that, I think, unless you have anything else to add, we'll take some questions.
Okay, well, we've got a lot of good ones coming in here. We'll go ahead and start with the first, but we just want to encourage our audience to keep sending them in also. As we've got plenty of time with our experts here. So, okay, our first question, this came in through email. My son is on a high dose of Pulmicort once a day and Singulair, which is taken in the evening. He still continues to have to clear his throat, and the frequency increases quite a bit when running. His nose also runs. Is this an allergy or asthma? And she notes that it doesn't matter if he's indoor or outdoors. And do we have any suggestions of what they could do differently?
Okay. Well, it sounds like we're talking a little bit about allergies. We're talking about triggers for asthma, essentially. So you've mentioned two potential triggers there. And one are those symptoms that we suspect are associated with allergies, which include that coughing, the throat clearing. And then cough can be associated either with that throat clearing or that cough could be associated with asthma per se, the asthma that's being triggered by allergy symptoms. Now, the other trigger that you mentioned was physical activity. So physical activity can also trigger asthma flares. So both of these are probably leading to a flare of asthma. And so it sounds as though the Pulmicort that's being used at this point in time with the Singulair are just not controlling the symptoms well enough. So it sounds as though a good idea would be to discuss this with your primary physician and let them know that his symptoms are a little that his symptoms are not well controlled, and so he likely needs to be stepped up on his management for asthma, and also addressing the allergies,
right? Because the runny nose. So the other thing we'd want to know is he having any other symptoms like a nighttime cough, Or is he actually coughing or complaining of chest tightness or shortness of breath with the exercise, or is it just the throat clearing? So looking at the asthma or the allergy control, which can then impact the asthma control. So does he need more allergy medication added to that? Maybe a pill, an antihistamine, or a nasal spray, and then possibly moving that Pulmicort dosing up onto a different medication potentially.
All right, we have another question. Can you take too much steroid for asthma? And what about using prednisone?
So there are, when you're using the term steroid, it can mean a variety of different things. As we talked a little earlier about the different forms of medications, steroids come in two forms. So steroids by inhalers, and we have steroids which come in a pill or a liquid form for some children. So if we're talking about prednisone, let's say, or prednisolone, these are the liquid and the pill versions of steroids, the oral versions of steroids. We can definitely have side effects that can occur if they're being used on a regular basis. But our goal is always to treat asthma symptoms and manage asthma symptoms so that we're not requiring frequent number of prednisone bursts. We use the term bursts to describe a 3 or 5 or 7 day course of steroids that are used to treat the acute symptoms and to get someone out of a flare. So with these, if they are being used on a regular basis, yes, you can have some side effects that result from this. And these can include headaches, they can include high blood pressure. Children can have a change in their behavior. Younger children sometimes getting very hyper or throwing tantrums a little more than usual. Some older children have mentioned that they just don't feel right. They feel like they feel different when they're on steroids. Sleeping disturbances. Most commonly, though, I think what we see is an increase in appetite during that time while they are on steroids. So no, these side effects are not fun to deal with. We do dose these oral steroids based on a child's weight until they are old enough or have a weight that's large enough to be able to use an adult dose. So we do try to use those sparingly. However, inhaled steroids are dosed in a much smaller, by a much smaller unit. So if you ever come across a inhaled steroid canister, you'll see that the dosing is actually in microgram dosing.
So you can see that. That's too big, too small.
It's hard
in
to say.
micrograms,
It's in microgram dosing. And I'd like to sometimes give the analogy that these medications are more of a topical medication. So the side effects are much less and not similar to the oral steroids. So the side effects here.
The side effects, I mean, so one of the big important things also is that not only, so the daily medications are in micrograms, which is tiny. It's 1/1000th of a milligram, and the oral steroids is in milligrams. The other important difference is that the inhaled steroid, if used appropriately, if you've used with a spacer and washing your mouth out after everything, only about 1% of that micrograms of medication gets out to the rest of your body. When you're taking oral medications, you're swallowing that goes into your stomach and then it goes everywhere. So your whole body's being affected by that. So we're always trying to decrease the amount of oral steroid, like Dr. Ramirez said, oral steroid exposure, because it goes to your whole body and can affect your adrenal glands and everything else. And long-term use can actually affect your eyes and your bones and other things. But the micrograms of the inhaled steroid, if used appropriately, should have very few side effects. Although over long-term use, we should be watching, again, for adults, we should be looking at bone density and for vision, also for glaucoma. So there are some other things, I'm sorry, cataracts, not glaucoma. So there should be things you should be looking at, but it is really the difference between milligrams and micrograms. So the proper use of the inhaled steroids is really, it is considered the gold standard and should have limited side effects.
Okay, another question, and this is a good one with the transition that we just talked about. The counter on my inhaler says there are still puffs left, but nothing seems to be coming out. What should I do?
So with the medications, this is an meter dose inhaler, and inside here, inside the boot, if you can look really closely, there's a tiny little hole, and that's where this medication sprays out. So if you have medication here, like I did before, you've shaken it up and you spray it out, this medication should come out freely. What can happen is this new, it's not actually that new anymore, but there's a propellant, and that propellant is kind of sticky. And what can happen is it kind of creates a cottage cheese curd inside here over the little hole. So before you take your medication, you need to look in there and make sure that that pinhole is actually open. If it's not, you can take a Q-tip and clean it out. The important thing to remember is never to put this whole thing with the canister into water, because this canister should never be in water, because the medication can actually get contaminated with the water through that stem. You could put this potentially and soak it if they can't get that little hole cleared up without it. But it's really important to visualize that, to actually look at that every single time and make sure that hole is open so that medication can go out freely. Because the problem is, even if it's clogged up a little bit, you're going to get less medication. So it's really important to keep that clean.
Okay, another question. My doctor recently diagnosed my daughter with asthma. He prescribed her a steroid inhaler and told me to use it every day. I thought steroids were bad. Should I be worried, and is this the right thing to do?
Yeah, so this kind of goes along with the previous question a little bit, where we do want to use that daily inhaled steroid. It's the mainstay of treatment to be able to address the underlying problem of asthma, which is that airway inflammation, that swelling. So steroids are going to work to decrease the swelling within those airways.
This part, yeah.
And so even if a inhaled steroid is prescribed at a high dose, these again it's microgram dosing. And if we were to actually prescribe a high dose to be used twice a day, every single day for a whole year, it still does not add up to having to use an oral steroid such as prednisone or prednisolone in the midst of an attack.
For 3 days, three to 5 days of oral steroids is more steroid than you would get by using this inhaled steroid. So it's actually very beneficial to her to use the inhaled steroid versus having to use the oral steroid.
So anything that we can do to control the inflammation on a day-to-day basis so that we can prevent the use of the oral steroids multiple times during a given year is really going to be the best treatment option.
Best treatment. And you think about having to breathe through this, even if the child is living a fairly normal life, they're actually getting less oxygen. And some people are worried about steroid, that they're going to make their child short. Studies have shown that that's actually not in the long term. If they do, they lose like maybe a quarter of inch in height potentially over long-term use. But you think about the fact not getting enough oxygen, that's more impactful on growth and other things. So it's really important to take care of that daily swelling, because even somebody with minor, I don't want to say minor, but mild asthma it's still at the high risk of, at the same risk of death as someone with very severe persistent asthma. So not to be scary or anything, but it's something that you need to take care of because it's important for their health and for their well-being. And has low impact on the medications have low impact on their body.
Yeah.
It definitely puts it in good context. So. Another question. I thought my kid would outgrow asthma. Is that true? Can they outgrow asthma?
So asthma is a very complex disorder, and many factors come into play when it comes to a child potentially outgrowing asthma. The important factors in terms of the patient's medical history can be if that child has eczema, and if they also have seasonal allergies along with their asthma. Again, this atopic triad, that term that I used earlier, if a child has all three of those, if a child has two of those, these are going to be the factors that are going to play a role in a more persistent phenotype, a more allergic presentation of asthma. That asthma can be a little bit more long-standing, and a child may or may not grow out of it. The likelihood of growing out of it is going to be a little lower. Now, there may be some children that early in life they wheeze with viral illnesses, and there isn't a diagnosis of eczema. There's no family history of anyone having asthma in the family. And so in that situation, a child may have wheezing with viral illnesses, and we are treating with asthma medications during that time frame, but perhaps that may be more short term. Only time will tell.
I think sometimes I've heard also that there may be these periods of kind of remission where the asthma kind of disappears for a little bit. Sometimes with boys, that's during teens, and sometimes with, as we get older, things change again. And particularly with women, they may have had asthma as a young child, but then kind of went through a period where they didn't have it, and they may get it back when they go when they become menopausal. So there's different components that we're just starting to figure out with hormones and other things for women in particular. But it also may depend also what we may move to a different area. So like your triggers may be here in Michigan, like ragweed is, we're a big ragweed belt right here. So ragweed may be one of your problems. So you didn't have problems when you lived down in, I don't know, let's say Florida, but then you move up to Michigan and then you start having problems again. So you have to think about those triggers and exposures also.
Another question we received. My daughter has a nebulizer machine, and we use albuterol only as needed when she is having a cough. She's 3 years old. I saw on the Facebook post for today's chat that the girl is using an inhaler. Could we use an inhaler like this even at 3 years old?
Yes, the answer is yes.
Yes.
The neat thing about chambers, this is a valve holding chamber, and it's got a valve inside of it. You can take this off, and this little plastic part here is actually the valve. So it holds the medication in the chamber, so it allows the child to take the breath as when they can. I can get it back together again. And with little kids, what we do is we put a mask on that. And so with that mask, we can then make a really good seal on that child's face, and then press the medication in and have them breathe in and out 6 to 10 times, and they get that medication. So that's really neat because this is a lot faster. You don't have to have electricity to run your nebulizer. So if you're out somewhere or maybe the power's gone off, you don't have to be worried about that because you can actually give that medication without that nebulizer, and you have the same effectiveness as the nebulizer.
And much more portable,
right?
As you said,
Yeah.
because there's no electricity associated with it. So this is something that we definitely encourage the use or the carrying around your reliever medication at all times, whether or not you feel you have a mild persistent asthma or you have a severe persistent asthma diagnosis, because at any point in time your asthma can flare.
Worse, yeah.
So it's always nice to be able to have that option to be able to carry your medications with you.
Particularly here in Michigan, because as we talked about initially, we have the weather changes. So it's been 80 degrees a couple weeks ago, and then down to 20 degrees, and those weather changes can cause problems. And then the seasonal allergies are coming out. The trees are pollinating, the grasses are pollinating, and then it's also the double whammy of the rhinovirus and other viruses that are going around right now. So you really do need to be prepared at all times to have something. Hopefully, again, with that daily medication, you're going to have less problems. I'm the perfect example. I take daily medication twice daily. I'm usually very, very well controlled, except my triggers are seasonal allergies. And so I got a cold and then have seasonal allergies on top of it. So I'm now taking my rescue medication every 4 hours to make sure that I don't have a severe exacerbation. With the chamber and no mask though, but just in the chamber.
Is there a way to minimize breakouts or pimples that result from using a nebulizer? It seems to be a consistent problem despite washing face immediately after use.
That might be actually, if it's used with a mask, that could actually be a reaction potentially to the plastic of the mask. I would look at where the pimples are, or where the mask, if it's a mask, if it's covering this, if the pimples are within this area, then I would call it part of the mask issue potentially. Maybe if the child's old enough to use the pipe and properly, always in the mouth, never just blow by. And I would maybe I would talk to your primary care about that, or your specialist, and maybe there needs to be a referral to a specialist for some testing.
Yeah, because at this point, I can't imagine that the pimples have resulted from the medication itself,
right.
And less likely to result from any of the propellant or anything else, a powder that's in the medications. So,
what is the best way to encourage regular maintenance medicine use? My child thinks he only needs it when he's coughing.
Oh, well, depending on the child, that's part of figuring out with your child is getting that schedule and maybe even talking to them. And there's some really great education material out there, both for kids and for adults, to show them and talking about what's happening inside your lungs, even when you don't have the symptoms. That's the hard part about asthma, is you may be feeling great, and you say, well, why do I need to take this medicine? I'm not having any symptoms. Why should I take something every single day? And the reason why you feel great is because you're taking it every day. And sometimes we don't even have awareness that something's going wrong in our lungs until it's really bad. And so what we're trying to avoid is having those bad exacerbations, but we're also trying to support, like maybe they're an athlete and they want to be able to do sports, and to be at your best to do those sports, you really need to have good asthma control. You need to be able to run fast. Maybe they're a basketball player or a football player or something like that. They need to have that control. There's some really neat examples of Olympians with asthma. Actually, a lot of Olympians have asthma. So you can be a top level athlete with asthma, but they take their medicine every day. And maybe that's something that you can talk to your child about, is how people that are very highly successful take their medicine every single day. And the reasons why behind that is to decrease, again, that swelling that's going on, that we don't even necessarily know that it's going on until we have another trigger that could put us over into an exacerbation.
I think having that discussion with your child at any point in time, trying to find out what their goals of care are and what it is that they want to get out day to day, whether it be their activities or being able to do what their peers are doing, and sometimes being able to use that as a means to encourage them to use their medications on a regular basis.
And also maybe figuring out what they don't like about it. Is it the timing that takes it? Is it like nasal spray? Sometimes kids don't like to take it because it drips down the back of their throat and it tastes nasty. Or is the timing, and maybe you can work the timing around a little bit differently. It's also, we didn't talk about this also, but it's part of this steroid kind of issue, is that it's really important to take the medication and then brush your teeth and rinse your mouth out. So that timing kind of issue, maybe you need to put it around something that they do every day. And this also encourages them to brush their teeth twice a day, which they should be doing, and figure out how that works. Maybe they're too rushed in the morning. Maybe they need to wake up a little bit earlier, or they need to do it at a different time frame. So there's I think a lot of ways you could fix that by figuring out, first of all, what they don't like about it and why they don't want to do it. And then talk about, maybe if it's just because they don't think they have an issue, talk about finding those resources to really talk about what's actually happening inside of their lungs. And maybe that'll help them be more engaged with it.
Yeah.
Do you advocate using allergy medicine to reduce triggers, and do any of them make asthma worse?
So, we've been discussing, definitely allergies can be a trigger for asthma and can, lead to poor asthma control if allergies are not being treated well. So we would encourage the use of medications to treat allergies. If you can do your best to treat the symptoms that are associated with allergies, whether that be your sneezing, runny nose, nose itching, throat clearing, sometimes even just the nasal congestion alone, these can all be symptoms of allergies. Some of those same findings actually are similar to asthma as well. There's the drainage, the runny nose, that you may be having. You're actually having some mucus within your airways, as I mentioned earlier. The congestion in your nose, you're also having congestion, airway inflammation taking place in your airways. So anything that you can do to try to minimize the twitchiness of your nose and allergy symptoms is going to be very helpful to minimize any asthma exacerbations and twitchiness and hyper-responsiveness of the airways within your lungs.
Yeah. You can kind of think of your nose being like a signal for your lungs. If you've ever had, I'm sure we've all had runny noses, clogged up noses, mucus in our nose, you can kind of picture that this is the same kind of thing that's happening down in your lungs. So when your nose is congested, and that feeling with that not being able to breathe, that they can kind of put that feeling in the same thing that's happening with your lungs there. But it is important to have those allergies controlled so they aren't a trigger for your asthma. And whether the medications themselves are talking about, again, histamines or Flonase or the nasal sprays, I don't think any of those would cause asthma to become worse. Taking those medications, it'd actually be the reverse. It would actually help the asthma be better controlled.
Right.
Can you overuse albuterol?
Absolutely. Yeah. Unfortunately, there's if you go to the getasthmahelp.org website, there's statistics on the morbidity or on the death rates of asthma, and most of these kids and adults have actually died with asthma in their hands. They overuse them, and that's nationally, within their inhalers in their hands, or they're on their nebulizers, and that's a national. I think it's actually worldwide that for some reason people will use their rescue medications, their albuterol, very freely, but are very hesitant. They don't want to take their controller medications. And with that overuse, you can actually flood the receptors, the parts in your lungs that actually take that medicine and cause the lungs to open up. If there's no longer any space for any more medication to go on, so those lungs won't open up anymore. They'll stop being responsive to albuterol. So when it becomes time for you to go to the emergency room and get treatment, that albuterol will stop working. So it's very important to take that daily controller medication to keep the lungs calm and less, as Dr. Ramirez said, twitchy, less ticklish, and only use the albuterol as needed. Now, that doesn't mean you don't use your albuterol. That means you use it when you need it for that coughing, wheezing, and shortness of breath.
Mm-hmm. Ideally, the goal of therapy should be that we are, only needing our albuterol at most 2 times a week. And even then, that may be a lot. Yeah. We'd really like to minimize the use. One inhaler of albuterol has 200 actuations in it. And so we really want to see that inhaler lasts a good period of time.
Yeah, almost a year.
Yeah, if we see families or patients coming in needing refills on their albuterol on a monthly basis or even more frequently than that, then that's definitely a sign that their asthma is out of control and that the albuterol is being used way too frequently.
It really is a signal.
Situation.
Yeah. It is very dangerous, right?
You mentioned earlier that there's a lot more becoming known about menopause and asthma. We had one question come in about the link between periods and asthma. Is there anything that you would want to share with patients about a link between periods and asthma?
I know that the School of Public Health here at University of Michigan is doing research actually right now looking at the connection between women's cycles with their menses and with asthma. And there is a link between the changes in hormones that happen with your menses and asthma. Sometimes it is almost a trigger for people with asthma. So what you can do is actually start calendaring your symptoms in reflection to when you're starting your period. And then maybe a couple weeks before and a couple weeks afterwards, and bring that to your primary care, to your specialist, and talk about that. It would be a time that you would want to be more conscious of making sure you're on your daily medication and have that rescue inhaler available for problems. But it'd be really the best way to kind of look at that would be try to really take a calendar and start writing those dates down. How often are you using your albuterol? How often are you having symptoms? And how does that line up with your periods?
We had a follow-up question. Can you please explain why it's important to rinse your throat and brush your teeth following the use of an inhaler?
Great question. Mm-hmm. The reason why is it is a steroid. It is a corticosteroid, but as we said, it's in micrograms, but it's still a steroid. And when you put a steroid into your mouth, you can promote the growth of things that are already in there that we don't want to grow, like thrush, and which is also Candida. So you want to make sure that you rinse your mouth out so you don't get the risk of thrush. You also don't get, sometimes it can cause your vocal cords to sound a little different. My voice sounds funny now, but because I'm having allergies and asthma symptoms, but you can actually get what they call dysphonia. It can cause your voice to change. You can also get sort of a sore throat, and it also stops the extra absorption of the medication, getting more medication into the rest of your body. Mm-hmm. So after I take my inhalers, after I take my controller medication, I'm going to make sure I rinse out my mouth, I gargle, and then I'm going to brush my teeth to really make sure. And so that really decreases my risk of having those other side effects to the rest of my body, and also just that risk of thrush.
So even though, this may be one of the more common side effects of inhaled steroids, I usually tell families that it's the most easily avoidable side effect. Right. And it's just as simple as brushing your teeth and rinsing out your mouth.
Using a chamber too will help decrease that risk, but then you also want to make sure you rinse out, even if you use a chamber.
We had another question coming over Twitter. How do you think asthma will be managed in the future? And do you think mobile apps and health technology will play a role?
Mm-hmm. Well, I think at least at this point in time, we'll be continuing to use inhaled steroids until new therapies,
Medications, yeah.
get developed by our great researchers out there. But there's nothing in the, near future that's allowing us to think that this will change in terms of medications. When it comes to the role of electronics and media and everything, I do think that that's definitely going to be playing a role in asthma management. I think one of the kind of simple examples that comes up in our clinic visits with older kids when they have their own phones or computers, or that they are able to manage their medications either by journaling on their phones or being able to set alarms on their
Reminders,
phones.
yeah.
There are definitely apps out there that families can use to try to help them manage their symptoms, or to even be aware of what's out there in their surroundings when it comes to environmental allergies. Right. So one of the websites out there actually is pollen.com, which is a very nice and useful website when it comes to trying to determine what allergens are in your area or where you might be going as well if you're traveling somewhere. So today, for instance, I actually looked up Ann Arbor, Michigan, area code 48109. Just to see what was going on today. And we are actually in a yellow zone for allergens right now. And this coming weekend, we're actually going to be in the red zone.
Even worse.
So even worse than today and tomorrow. So I urge anyone in the area to take their allergy medications if they're going to be having any concerns. But definitely there, another website out there, I think, is one set forth by CNN.com, also similar to trying to get an idea of what allergens are in the area, and just so that you can be able to either avoid those triggers, avoid those allergens, or be able to remind yourself to make sure you take your medications.
Michigan also has a website that actually tracks ozone and triggers also. So that's another thing to look into. I'm sorry, I don't have that right website, but the new technologies are really neat because they can help you track your symptoms and your medication use. It can be, there's some games that actually kids can play and they can win badges and other things. So it gets them more engaged in the control of their asthma also. And there's also some great programs also that help you communicate with your provider, because you can actually link your provider up with that program so they can see how your asthma control tests, your peak flow meters and other things are going. So you can actually communicate with them about how your asthma control is working.
So I think a lot of these either apps or websites can definitely provide your family with more information about asthma and what's triggering your child's asthma. And this is all information that's useful for anyone who's part of the team to be able to manage symptoms. And so it helps when you come to a clinic visit to see us and you're able to pretty clearly say, oh, this is what I noticed, this is what I've journaled so far, and I needed to use my medications at this point in time. And I realized, oh, there was this trend of, either allergens were really high that day, or, oh, I went for a really long run and I think it was that, physical activity that triggered my symptoms. So it's almost easier to be able to find trends when you do use some of these electronics.
It helps you investigate everything.
We've had some parents mention the idea of a medication vacation before. How important is it to talk to your clinical provider before taking a vacation?
Crucial.
Yes.
Crucial.
The simple answer is very important.
Yes.
There are some children who may not need asthma medications, their controller medications on a regular basis. They may not need to use their controllers year-round, 365 days of the year. But that understanding comes about after having that discussion with your primary care physician or with your specialist, where we, over time, are able to determine that that's truly the case. And there are other children that, regardless of trying a medication vacation, so to speak, actually will still have symptoms. And so, yes, they do need to take it year round. And so they may not actually have the option to be able to stop their medications or to step down the dosing of their inhalers.
Yeah, as Dr. Ramirez said, we do have some kids that come that are really just triggered by colds primarily. And so sometimes we can put them on before school starts because that's when everybody gets sick. And then we take them off when school stops. But that really needs to be managed and orchestrated, really like put together. We got to look at all the pictures. When have they had problems? When have they had oral steroids? When have they had hospitalizations or emergency room visits? Or you just see that they're poorly controlled. When does that happen? And we look at all those dates and figure out when's the best time if they can. Again, some kids can't ever do that, but some kids can take some times off. But that's how we want you to see the doctor regularly, not just once a year, because it's really difficult to figure that out.
All right, well, we're just reaching our 1 hour mark here. So I want to thank everybody for joining us. Thank you to our panelists. I did want to mention that the pediatric pulmonology team here at Mott Children's Hospital sees patients both here in Ann Arbor at the CS Mott Children's Hospital facility, as well as now you're seeing patients, I understand, at the Northville Health Center.
Yep, we have some of our physicians out there.
Very convenient, parking right up there at the door, which I know is a big draw for a lot of people. So, and if you'd like to make an appointment with either the patients for our pediatric pulmonology clinic or any of our specialty clinics here at Mott Children's Hospital, you can call toll-free 1-877-475-MOTT. You can also visit our website, mottchildren.org. The webpage for the asthma program in particular is mottchildren.org/asthma. So you can learn more about the program and a little bit more about the providers that care for our patients. I want to remind everybody that this web chat was recorded and is going to be online. You can go back to mottchildren.org/webchats to watch this one later, share it with your friends or others you think may be interested in. We're also going to be sending out a brief survey after today's chat, so we would like to encourage you to take a moment to fill that out and let us know about topics you'd like to hear about from us in the future. On that note, if you're not already following us on social media, we'd like to invite you to follow us on Facebook. We're facebook.com/mottchildren, or on Twitter, twitter.com/mottchildren. Follow us. That way you'll hear more about additional upcoming chats we have, and we always have other interesting things we're sharing with everybody. So again, I'd just like to thank our panelists, Karla Stoermer Grossman, a certified asthma educator, and Dr. Ixsy Ramirez, both with the pediatric pulmonology team. And thank you for our audience.
Thank you.
Thank you.